or when do you take them for endovascular procedure?
So what I would look at is what I call anatomical suitability. And so the most important thing for me at the very outright is, what does the neck look like? And the neck would be defined as where the aneurysm starts up to the kidneys. And obviously the longer that is, the better off you are. The more tube-like that is, the better off you are. And so if they have what I would call a good neck, if they're anatomically suitable and they need to get fixed, then that's the person I will start figuring out how to get that done. The ones that, what I will tell my patients is, if you think about these grafts, if the more tissue that I can put on an endo graft, the better chance I have of getting a seal. The less tissue I put on a graft, I have a very short neck, the bigger chance I have of getting an endo leak. And we can talk about that a little bit later, about what endo leaks are and what they involve. But so I want to have a nice long neck. After I get that, then I want to look at what their iliacs look like. How are their iliacs very, very heavily calcified? Are they tortuous? Are they tortuous and heavily calcified? Because these are very large catheters that we're trying to transport into the aorta. They're not like the angiogram catheters, which tend to be extremely small in comparison. So I have to make sure that the access to get to the aneurysm is big enough to allow me to push these large catheters. There's nothing worse than trying to fix an aneurysm to rupture an iliac while you're trying to force one of these big catheters up, and you can't do it. So it really is, those are the two things that I will really focus on, the neck and the access. Once those are sort of, yes, they are a candidate, then the rest of it tends to be a little bit mundane of which graft am I going to use, what size graft I'm going to use, how big, how long, etc. But once I've looked at the neck and the access vessels, then I can pretty much guarantee that if those two are acceptable, then I can fix this.
Definitely, as some of us that are involved in this procedure can easily tell, what used to be a 6-hour procedure has been reduced to, our procedure time is like 45 minutes to, in a good case, to under an hour and a half in a complicated case. Right. And with a small incision on one access side of the groin, even in some of the instances, even that is being eliminated. Right. And some of the operators, if the arteries are suitable, have completely used a full percutaneous technique, where you end up putting sutures from the skin level, so there's not even an incision. Right. But still, even if you assume that you make a small incision on one side of the groin, where we take the larger graft device, and the other side is a small insertion site with like an angiogram, almost like a 9-French sheath, and you pull it out, you can get hemostasis by putting a little suture or a plug. And even on the larger side, we can use a couple of sutures or invite a surgeon to make a small incision. And once that incision is made, insertion and of the grafts and completion of these procedures, looking at it under x-rays for a few minutes, taking maybe a couple of shots once we are done. And typically we do it in the OR suites, and I don't know, in HOMA you're still continuing to.
Same thing in the operating room.
But there have been instances where we have taken this procedure and taken it to the cath lab, just to have the benefit of better visualizing, better imaging equipment. But again, this varies from institution to institution. That is completely an individual preference and an institution preference. But simply the length of the procedure has been reduced to 1.5 hours from skin to skin. And then you get out and you're extubated probably within the next few hours. And in the ICU, you're having a meal probably 5-6 hours after you wake up from the anesthesia. In the evening, you're out of the bed and walking around. And in most good cases, we either discharge them next evening. And in more complicated cases with difficult access or whatnot, maybe they'll spend 2 nights in the hospital. That is a significant difference from where we were 10 years ago, and even now when they undergo open surgery. I want us to run some of these, and so we can show some of the pictures of the grafts, what they look like once they're implanted in the patient. Here, as you have run the previous ones. And we are gaining, here we have one more aneurysm here, as all the audience can see. There are 2 images, or rather 3 images next to each other. The one which is kind of red and colorful and is more 3-dimensional rendering of it. It's a 3D reconstruction rendering of the aneurysm. You can see that huge ballooning portion, and the red kidney bean shaped organs are kidneys. That's where the beans derive their name. So those are the kidneys and the renal arteries to that. Above that are the celiac and superior mesenteric arteries. On to the right, on the upper hand side, where the yellow arrow is pointing out, you can see a grayscale image of the aneurysm, and down inside you see actual complete measurement of the sac here. And you see on the right hand side at the bottom, you see the spine. Above the spine lays the large abdominal aortic aneurysm. Next image, please. And here, this is an image after the exclusion of the aneurysm, and you see this whitish kind of somewhat shiny device on the lower right-hand panel. You see it kind of bifurcates or splits like a fork, and with kind of hyper-intense, like whitish, hyper-white spots that represent the stent graft. On the right-hand side, in a longer panel, the audience can see that there is kind of a split. Immediate, you get the exclusion instantaneously. Of course, once we are in the cath lab, you finish it, you take a picture, you don't have any more visualization of the aneurysm sac, which is a very rewarding sight. Move on to the next image, please. And here is another image of next image. Next. Yeah, and this is again another nice image where the audience can appreciate the presence of this bifurcated stent graft device in the aneurysm. Once it is excluded, you see this hyperdense material with a mesh-like appearance, which is split in a fork-like manner, extending into both the iliac arteries, or the big arteries leading on down to supply both sides of the both pelvis, buttocks, and all the lower extremities all the way. And go on to the next image, please. And here you have a far more dramatic looking aneurysm. Here you see like this large red kind of a softball size aneurysm. These are so-called saccular aneurysms that we are far more worried about typically than the so-called other fusiform aneurysms, which kind of which involve the entire aorta, and they don't bulge out and look like a little softball there, and the incidence of complications tend to be higher, and the incidence of rupture tends to be higher. So you're a little more aggressive in approaching these so-called saccular aneurysms.
You ought to notice that there's no clot in there either. You notice
so it happened pretty fast. Obviously,
this gentleman was 92 years old.
He got there pretty.
Yeah.
But it's amazing, and if you assume that the years before, if you take a 92-year-old man, there's no way on earth you would, unless if he is absolutely in tip-top shape, nobody in their right mind would put them through an open abdominal aortic surgery. Whereas these days, if he's, all in all, his arteries, besides that, look very healthy.
They were very good.
So he is a very good candidate for abdominal aortic aneurysm. You see above that softball or the actual aneurysm, you see a nice narrow neck, and there is this huge bulge in the aneurysm, and then comes down and the arteries narrow down to normal dimensions. So it's an ideal case to encounter. Go on to the next image, please. And this is after exclusion of it. Immediately, instantaneously, you see the result that the AAA is really excluded. That's why the so-called description that AAA exclusion or endovascular exclusion of the aneurysm, you're basically excluding it with a stent graft. So,
Cal, just an aside. Just so the public can understand, what you're doing by excluding is you're creating a new channel. You're creating a totally new artery within the artery.
Right.
You're going inside it and excluding the portion that's like the bubble.
Right.
Think of it as a bubble from a bubble gum. When you blow on it, eventually it's going to pop. You basically are putting in a new tube in there when you put these endovascular grafts.
Now, fortunately, since most of my patients tend to be 90 years old, or or he was an exception. But I think the way I describe it is the old inner tube days. And what you would do is you would put an inner tube inside this tire that has a blister, and all the air would be in the inner tube. And so I'll describe it in that way, because a lot of patients, when they go for this, are you going to take the aneurysm out? What happens to the aneurysm?
Correct.
And so you can give them sort of a visualization of what I'm going to do is put an inner tube inside this aneurysm. I'm going to put a tube inside this aneurysm, and all the blood is going to stop being pumped to the aneurysm, and it's going to depressurize, and over a period of time it's going to shrink. And so if you had a tire that had a big blister on it, and tires are very, very expensive, you may think about putting an inner tube. I don't know if anybody would do that, but I mean, obviously that's a sort of a conceptual idea to put an inner tube into that thing, and all the air is in the inner tube, so if something happens to that blister, hopefully all the air would stay inside that inner tube.
Right. I mean, of course, going back again to the original concept of the fit really ballooning like a water bottle or like a little bubble. Anybody can visualize. All of us play with the little balloons that we put water in, and if they're bulging out and the wall gets stretched out and thin, And if it is seeing more and more pressure, and either because the patient is untreated blood pressure or even otherwise it is unchecked, they're putting the simplest acts that we perform every day, including going to bathroom, lifting a weight, getting up from a chair to getting into a car, increases the intra-abdominal pressure and thereby putting extra pressure on the so-called aneurysm sac from rupture. The goal of putting be it a surgical graft or an endovascular graft is excluding that, so that sac, that weakened bubble, does not see the blood pressure or the flow of blood, whereby by getting contact into it increases the susceptibility to rupture. So now that we talked about endovascular aneurysm repair and showed some of the grafts, what are the pros and cons of endovascular aneurysm? While we talk, it's a nice procedure, it's reduced in duration, it's less morbid, patients get out and do all that is nice, but what are the pros and cons of EVAR?
The first thing obviously is access. I think that's the big issue, trying to get in there. The more, the longer we do this, the further the envelope we push, and so there's different techniques with fenestrations, making holes in grafts, putting chimneys in grafts, things like that, that we have now taken patients that are not only not surgical candidates, but they're not endovascular candidates. They're really a bad combination of both, and try to figure out how can we fix them with an endovascular way. Can we basically deconstruct the graft on the operating room table, make holes in a certain spot based on the CT scan, construct a graft back in, and then deploy that successfully. And that's a 4-hour procedure. That's something that takes a lot of time, a lot of diligence, a lot of specific measurements, but things that can be done. And so I think what we're seeing now is across the country is there are certain centers that are really taking endovascular and pushing it in those patients who truly don't have another option. The option tends to be medical therapy, which is of naught. You can't do anything other than treat the risk factors, but once they get to a certain size, they're kind of stuck. And if the surgeon looks and says you're just not a surgical candidate because of XYZ, then what can we do from an endovascular standpoint? So we've done several in HOMA. We've done several hybrid operations where we've debranched people and came in and done an endovascular graft. We've done some fenestrations. We've done some chimneys, what's called chimney grafts, and all those are just sort of very advanced techniques that we're able to take this envelope and push it a lot further than we have in the past.
That's right. I mean, as clearly, like many other centers, which includes your center, the very first aneurysm that I was scrubbed in was with you when we were training some 10 years ago. And here we are, and it is kind of definitely from the inception of the grafts to now, they've come a long way where the access and the size of these endovascular grafts, which used to be humongous, somewhere up about 24 French, now they're reduced somewhere up to the 19 French, or even they're talking about 14, 16 Frenches. On the other side, it has never been a problem. So it's really come a long way. And of course, those of you that are in the forefront of this procedure have definitely pushed the envelope and taken to the extent that there are almost no patients that are not a candidates for, and in those patients that are extremely difficult, you kind of stage them so carefully by debranching it or planning them, creating these fenestrations and other things, which are not your everyday bread and butter. It is not within the realm of exclusion, endovascular exclusion for all the physicians. These are for physicians with hundreds of cases or multiple cases with extraordinary surgical backup and extraordinary endovascular suites and experience. This is not something that physicians with average experience should be attempting. But all in all, patients simply have to understand that these are procedures which are not only available in the rarefied centers like Cleveland Clinic or Houston or Beth Israel or wherever. They are available in HOMA, in Lafayette, and even Opelousas every day. So, I mean, we'll take a little break here and come back to finish our discussion about the follow-up after aneurysm exclusions.
Even the very best heart care is of value only if you have access to it. So here's our pledge. If you have chest pains or symptoms of a heart attack, you'll be seen at any hour, day or night. If you don't have symptoms, but you or your doctor have concerns about your heart, you'll be seen within 48 hours. And even a routine heart check will normally be scheduled within a week. CIS is one of the largest, most advanced facilities in the South with an international reputation for treating heart disease. Call us to schedule your appointment.
I never thought it would happen to me.
I never thought it would happen to me. I didn't know women my age were at risk for heart disease.
Heart attacks are by far the most common cause of death in the United States of America.